Here's a number that captures the whole story. In one analysis of Medicare data, a routine colonoscopy cost the program about $400 when it was done in an independent doctor's office, and about $1,100 when the very same procedure was done in a hospital-owned clinic. Same doctor, same scope, same 15 minutes. The difference is a hospital facility fee, and it grows the moment a hospital buys a practice and bills that office under its outpatient rates. Now that figure comes from a physician-commissioned analysis of older Medicare rates. So treat it as the shape of the gap, not your personal bill. But the shape is the whole point, and it's why the hospital near you keeps buying up doctors' offices. Let's follow the money. Here's the mechanism in plain terms. When a hospital acquires a physician practice, it can bill for care in that same office under the hospital's outpatient rates, which, for the identical service, pay more than an independent office earns. On many visits, an independent office charges little or no separate facility fee. The hospital's version is far larger. One caveat worth stating plainly: Medicare curbed this for brand new off-campus clinics back in 2015, so the effect bites hardest at grandfathered and on-campus sites, and in commercial insurance, where it's largely untouched. You didn't walk into a hospital, but on paper you did. And that difference is worth so much money, it has reshaped who owns American medicine. Let's answer it like an operator. Why has nearly every hospital system spent the last decade buying up independent doctors' offices? The story runs through a payment rule that makes the same care cost more, a collapse of private practice, a second wave of corporate buyers you might not expect, and to be fair, a genuine case that some of this consolidation actually helps. Two things are true at once. The price effects are real and well documented, and the reasons doctors sold are real too. Let's hold both. Start with the scale, because it's staggering. As of early 2024, by one widely cited count, roughly 78% of American physicians no longer owned their practice. They were employed by a hospital or another corporate owner, up from about 62% just 5 years earlier. One caveat on that figure: it comes from a physician-commissioned analysis, and it runs a little higher than the American Medical Association's neutral survey. But both point the same direction, and hard. In the span of a decade, the independent doctor, the one who owned the shingle out front, went from the norm to the exception. The American Medical Association, a neutral source here, tracked the same collapse. In 2012, about 60% of doctors still worked in a private practice they had an ownership stake in. By 2022, that had fallen below 47%, the first time in the survey's history that owner physicians were a minority. And in just the 5 years between 2019 and 2024, more than 44,000 practices were acquired. Two forces pushed in the same direction. One was survival. When elective visits stopped in 2020, a lot of small practices ran out of cash and sold. The other was value. A practice is simply worth more to a hospital than to the doctor who runs it. Both are real, and they reinforced each other. To see the second one, you have to look at what the hospital can bill the moment it owns the place. There are 4 big reasons a hospital will pay a premium for your doctor's office. 1. The facility fee we just met, billing the identical visit at a higher rate. 2. Referral capture. Once a system employs your primary care doctor, the scans, tests, and surgeries she orders tend to stay inside that system, feeding its high-margin service lines. 3. For the roughly half of hospitals that qualify as safety net providers, the 340B drug discount program. Such a system can register an acquired clinic as an eligible site and widen the spread on the drugs it buys. And 4. Leverage. Every practice a system absorbs makes it a little more must-have for insurers, which means higher negotiated prices across the board. Add those up, and the office is simply worth more under a hospital's logo than under the doctor's. Put a number on the facility fee. In one analysis of Medicare data, a routine colonoscopy cost the program about $413 in an independent doctor's office, and about $1,090 in a hospital-owned clinic. Same scope, same prep, same 15 minutes. The difference, roughly 164% more, was largely a hospital facility fee, far bigger than anything the independent site charged. Two honest caveats. This is a physician-commissioned analysis, and those exact dollars are Medicare rates from about a decade ago. So treat them as the shape of the gap, not today's precise prices. But the shape is the point. Change the site's billing label and the price jumps for care that didn't change at all. This is the whole episode in one picture. And to be clear, these are what Medicare paid, not a personal bill. On the left, the independent office. On the right, the identical service in a hospital-owned clinic. The care is the same, the payment is not. And it isn't unique to colonoscopies. Across many common services, Medicare, and commercial insurers even more so, simply pay more when the exact same procedure happens in a site that carries a hospital's billing label. For some imaging and drug administration services, the hospital-owned price runs 2 to 5 times the office price. The building didn't get better, the billing code did. Zoom out from one procedure to the whole practice. A peer-reviewed study found that after a hospital acquired a physician group, the prices for that group's services rose about 14%. And the researchers modeled where that increase came from. They estimated roughly half was the added market power of a bigger system, and much of the rest was the facility fee mechanics. The same care rebilled at hospital rates. That split is a model, not a clean measurement, but the headline is solid: 14% more, for nothing you would notice as a patient. Multiply it across tens of thousands of acquired practices, and it becomes real money flowing out of paychecks and premiums. You can see the strategy in the data. When researchers looked at where doctors send patients for an echocardiogram, a heart ultrasound, hospital-employed physicians routed it to the higher-paid hospital setting about 70% of the time, versus 24% for independents. Same test steered to the pricier room, and the 340B drug program shows the footprint too. It ballooned from about $6.5 billion in 2010 to nearly $44 billion by 2021, as systems registered thousands of acquired clinics as eligible sites. The count of hospital off-site clinics jumped from around 6,000 to nearly 28,000 in under a decade. The Congressional Budget Office named this kind of integration the single biggest driver of that growth. And here's a twist most people miss. It isn't only hospitals doing the buying. A second wave of corporate owners, private equity firms, insurers like United Health's Optum, even pharmacy chains, now employ a comparable share of doctors. Private equity runs a specific playbook: buy a platform practice in a fragmented, procedure-heavy specialty, bolt on competitors, and raise prices. After private equity firms rolled up gastroenterology practices, one study found prices rose roughly 28%, with professional fees jumping close to 80%. The Federal Trade Commission alleged that one private equity firm used an anesthesia group to buy up nearly every large anesthesia practice in Texas and push up prices, an allegation the firm disputed, and that the parties settled in 2025 with limits on future deals. So the trend is bigger than hospitals. It's the corporatization of the doctor. Now, in fairness, there's a real case on the other side, and it isn't just spin. Running an independent practice today means shouldering an electronic health record system, night and weekend call coverage, and a mountain of billing and compliance work a solo doctor can barely afford. Joining a system can bring genuine coordination. One shared record, one team, fewer dropped handoffs between your doctors. And the newer payment models, the ones that reward keeping patients healthy rather than billing per visit, are built for larger, salaried, aligned groups. For a lot of physicians, the choice wasn't independence versus a system. It was sell or close the doors. The pull toward consolidation isn't only greed, a great deal of it is exhaustion. So does all that coordination actually pay off? Here's where the evidence gets stubborn. A 2024 systematic review pulled together 43 separate studies of hospital-physician integration. The consistent finding across them was that integration raises costs, and that its effect on the quality of care was, in the author's own word, unclear. Some systems genuinely do coordinate better, but at the level of the whole country, the promised savings from all this consolidation simply have not shown up. The reliable, repeatable effect is higher prices. And a large chunk of that, remember, is mechanical, the facility fee, charged for care that never moved. So here's the whole thing on one card. 1. The independent doctor's office collapsed in about a decade, pushed by real burdens and pulled by real money. 2. A major financial reason to buy one is that the same visit can be billed at higher hospital rates the day the ownership changes. 3. Prices reliably rise, while the promised quality payoff stays unproven. And 4. The reform most often floated is site-neutral payment, paying the same rate for the same service no matter what label the building wears. The Congressional Budget Office has estimated that a broad version of that could save on the order of $180 billion over a decade, though which services it covers and whether it passes is very much still in play. If you take one thing from this, hold two things at once. First, a lot of this consolidation happened for real reasons. The crushing cost of running a practice alone, the pull of coordination and scale, and for many doctors a plain choice between selling and closing. And second, however it happened, the effect the evidence keeps finding is that the same care tends to cost more once a hospital owns the address, because our payment rules pay by the building's label, not the service. Both of those are true, and good policy has to reckon with both, which is why site-neutral payment, paying the same for the same service, keeps coming up. The next time you spot a facility fee on a visit that felt exactly like it always has, you'll know what it is, why it's there, and why almost every hospital in America wants to own the room you're sitting in. So the next time you notice a hospital's logo appearing on the little medical office down the street, you'll know it's not really about the building. It's about the billing label, the referrals, and the leverage that come with it. We've watched systems grow by swallowing doctors' offices one at a time. Next time, we go up a level. What happens to your prices when two entire hospitals merge into one? And why the antitrust math is trickier than it looks. For more on how the system really works, visit shanewelter.com. I'll see you in the next one.